Sharing more
Please, Morse belongs to nobody in my family.
I know. that you know of.
Right, you're right. Could be someone somewhere.
Okay, you ready?
This is medicine, right?
I think you're online.
Hi, everyone. Welcome to Essence of Medicine. Today, we're going to be talking about infection. My name is Alyssa Haber.
Dominic Moore.
And I'm Dr. Abbasi for Essence. Now, medicine. We just talked about in the last the thing, what separate the medicine from the rest of the science?
Dominic,
Yes.
shall we take this about 300 feet up to explain why?
Yeah, go. I mean, people might not have watched the
Yeah,
previous
well,
test.
Let's preface this by saying, go watch a little bit about bacteria and viruses, because we could have talked forever about that. Biggest thing that I learned here is science, or what we talk about with the bacteria, science is such a small part in all of this, or medicine is such a small part of science. So when we break down the science aspect, it comes to having to implement that science to get medicine.
So very good. Go ahead.
Specifically, I think of, when we take that silence and we're implementing it, it's in the idea of diseases or, disease states and just treatment. Pretty much broadly, those two, those are very, very big topics in themselves, but when you narrow it down, that's kind of the basis of it. You have a problem, and what are some solutions?
In 1,000 years ago, the only science or only discipline, not science, only discipline of wisdom that existed was theology.
Okay.
1,000 years ago. And then there were these people, the lovers of wisdom. They were before that, but then they sort of died out, and theology, science, or the philosophy of God was the only thing. But then after that, around the 1200, 1300, 1400, the other people start going beyond theology, thinking about the nature of nature of things. Why do we exist? These lovers of wisdom in Greek is called, it's called, of Latin or Greek, I forgot which one, it's called philosophy. Phil
Makes sense.
meaning lover of, and Sophie meaning wisdom, lovers of wisdom. Then this lover of wisdom actually was the only kind of professors in the university, the philosophers.
I think it's Latin. Sorry,
Yeah.
just kind of got to me.
Yeah. And then until Galileo said, that's not enough. Look at the mathematician. They do a great job. I want them to have their own. I want them to get paid as much as the philosophers. I want the mathematician get paid as much as philosophers. So Galileo established that mathematicians deserved as much attention and pay as philosophers or theologians. And because until then it wasn't the case. But then they will say, but you know what? Oof, that mathematics, that's for children. That's just a little of the thing and so on. That's
Interesting.
But then we had mathematicians, then we had great mathematicians, and then some of the mathematicians connected 1% of the mathematics to real life. They were the physicists. And then some physicists noted that, if you mix certain things together, they react in certain way. They were the chemists. And the chemists know that some part of the chemistry is life-related. They call it biochemistry. And the biochemist noted that this complex molecule come together, they make life. They were the so-called naturalists. We call them today biologists. And those biologists says, you know what, screw all of that. I just want to treat humans. And they were doctors. I cannot tell you for how long doctors were so unimportant, and they sucked so at everything. Everything we did, we harmed people more than. You should go read history. Things they did to the king, Louis XIV. Like they took his teeth out and they made a hole here from his mouth to his nose. You could regurgitate. They would give him the mercury and lead. They would bleed them out. Like we thought that we had a the podcast about that. They wouldn't
Yeah.
wash their hand,
Mm.
and the woman in Vienna would beg not to be admitted to the hospital with the doctors because everybody who would go there would die
Mm.
because they wouldn't wash their hands. And we crucified the only one person who said you should wash your hand,
Mhm.
Ignaz Semmelweis. Remember Ignaz Semmelweis. That is how we have treated. Now, we have sucked as being doctors and physicians for a very, very long time. And that's what medicine is, being a doctor. We still suck at it. That's for many of my colleagues that they think that, it's okay to have 20,000 times more risk of 2,000 times more risk of infection
Mhm.
compared to what we do. And they try to prevent the patient to get that. So you suck. Okay. But
Quotes.
okay, so medicine is the biology of human, and more importantly, the biology of the disease of the human.
Mm.
So there are many categories of disease in human. Infection is one of them. What are the other categories of disease in human? Genetic.
Mhm.
Yeah, genetic disease.
So how can somebody be sick? You can poke a hole in him, trauma.
Yeah, exactly.
You can, they can have a genetic problem.
Correct. You can
They
pass
can-
it.
They can have a degenerative, like you just get old and certain areas don't work,
Mhm.
and you can have infection, right?
Mhm.
There are 5 areas, but
Mhm.
today we're going to only talk about infection.
Okay.
What are infections?
Infection is basically the buildup of a bad, or the body, I shouldn't say bad. Again, not all bacteria is bad, but when the body has a overproduction of a foreign substance, bacteria,
Bacteria or virus?
virus.
But today we want to talk only about, you see how limited we are today? We are only going to talk about bacterial infection.
I'd also like to give a shout out to my little friend Fungus.
You and your fungus.
I'm just saying he's underrepresented, but
Truly is.
Mhm.
Truly is. I mean, well, we should actually have a podcast about fungus only, because things that we really found out about funguses, it's just unbelievable. So
Mm.
that blows your
And
mind.
hard to
as well.
treat, so.
But
yeah.
let's talk about infection, bacterial infection related to surgery.
Okay.
Okay, well, today morning we talked about, now we do the surgery, we open up the skin, we give bacteria a path to go in. Obviously, we reduce that
Mhm.
by aseptic techniques, sterilized instrumentation,
Mhm.
and the pre and post-operative antibiotic and so on and so forth.
Mhm.
All of that has made surgery possible, because
Mhm.
it wasn't a long time ago. If you had a brain surgery, 80% of the time you would die of it.
Yeah,
They-
that makes sense.
9 out of 10 people would die of it.
Especially if they're not washing their hands.
Jeez, must have been
Well,
easy
no,
to be
we
a brain
weren't washing
surgeon
our
back
hands
then.
by then.
Okay,
No, the
okay.
father of neurosurgery is Harvey Cushing, who really brought those techniques that reduce the risk of infection mostly. So people wouldn't, even if it wouldn't get better, at least they wouldn't die of brain surgery. You see how low our threshold
Yeah,
is?
those are some standards for
Yeah.
sure.
So we cut the skin, we open it up, we expose it to bacteria.
Mhm.
We reduce the number of the bacteria with all the techniques we talked about,
Mm.
but some of them still get there. We give
Mhm.
them antibiotic to kill those that got in, we couldn't wash out.
Mhm.
So one of the major thing is irrigation. If you have an open wound, irrigate it.
Mhm, mhm.
But more importantly, make the opening, make the damage to the tissue less. That is the best way of reducing the rate of infection. The other best rate of reducing rate of infection is don't produce dead tissue. What do we do surgery with?
Mhm.
We cut it,
Mhm, mhm.
start bleeding. How do we stop bleeding?
Compression.
Really?
When you start,
When you are with Dr. Kim, you start compressing, compress here until bleeding stops.
My
How
friend
does it
Without
stop?
Cautery.
cautery.
Cautery. We burn the tissue.
I thought you were talking you. We don't use cautery that often.
Not in our surgery, but generally.
Too fast.
In
not our
general surgery. Oh, absolutely. Bipolars and
And the bovies and so on.
Bovies,
We
yeah.
literally use electricity to
riot.
literally cook it. Have you guys heard of so-called aquamantis?
No.
Aquamentis.
Aquamantis is a
Aqua
device.
water.
well, it's called aqua mantis, not because of its water, but it has to irrigate a lots of water while it's doing that. I think that the word aqua comes from.
Is it the device that
It's a
looks like a?
bipolar that use 120 volts, that the electricity that come from your wall,
Mhm.
and it literally cooks, it makes steak as you go in the human body.
Oh, yes, it does.
Okay, actually,
Have
I
you
thought
heard that?
mm-mm.
No, but we have had event recently where we've got to cook and
Major
Dominic's
tissue.
got to experience that for one of the first times here. So we know
so
we
what
know the
happens is-
outcome.
So, but sometimes it's needed. You see, patients start bleeding.
Mhm.
Bleeding can kill you.
Yep.
Yeah.
Bacteria can kill you, but bleeding can kill you now.
Yeah, it'll kill you today,
Yeah.
not 48 hours later.
So what
Yeah.
do? We get that bipolar 120 volt from the electricity from the wall. It literally cooks all the tissue, coagulate all the vessel to bleeding stop. But in a regular surgery, that's what you do.
Correct.
You cut it, you stop the bleeding, then you go cut more, you stop bleeding more. If you reduce that, then your risk of infection is less. That's why OLEF, what we do,
Mhm.
has what the rate of infection for OLEF?
What, 0.2%?
Zero,
Zero.
zero,
Zero.
point-
Zero.
Zero.
0.3 or 2%, 0.3%, but not a
I said
single
0.2.
take back. Yeah, but that's the same. But
Yeah.
but not a single take back to surgery for incision under, not a single take back after almost 2,000 patients that we have done.
I was going to say, actually, these numbers might be a little bit lower now.
Yeah, yeah, not a single take back and 0.2. Regular surgery for regular spine has 3 to 5%.
Mhm.
Now, we reduce that with all those things, but if you cook tissue less, when you grow bacteria in the lab, what do? You give them
Nutrients.
nutrients,
Nutrient, like-
medium, you give them dead tissue for them to grow on.
That's the little petri
Agar-agar,
dishes.
petri dishes and so on. So literally you are producing a lot of dead tissue in your surgery. If you cook the tissue, if you open it up, there's another important thing in the surgery where you can prevent the infection. Imagine you do a regular spine surgery, you cut the skin, you cut the fascia, you cut all the muscle, you cut all the bone, you create dead tissue. If one of the small areas start having an infection, it's an open highway
Mhm.
to all the other area. Whereas in our surgery, you see that I never connect those two dots that connect, even if they're 2 millimeters away
Mhm,
from each
correct.
other.
Mhm.
I don't connect them because if one of them get infected, the others won't. And that exactly happened. In 1,500 surgeries that we have done, we got 3 infections. All 3 of them, only one of the hole got infected. It didn't spread to others
Mhm.
because the fascia underneath was intact. It didn't spread down. And
Mhm.
we treated them for 5 days of oral antibiotic, and not a single take back.
Yeah, I mean, honestly, that's less than you do for a sinus infection. And
True.
if anybody, just in case you're kind of curious, your sinuses are this huge tract. They go through all sorts of different parts. You get earaches, throat ache, like all that stuff.
So
So
our
even
surgery-
less than that.
Our surgery has a very, very low risk of infection. But let's talk about infection. When you get it, you have open
Yeah.
surgery, you get an infection. Now, we did the surgery today. The nurse on the floor calls you, come back here, it's infected. What's your response?
I would politely chuckle under my breath more than likely
Why would you chuckle?
because
I would chuckle too, but why would you
Ah.
chuckle?
I would know from my schooling that infection or takes longer than that to cause a systemic reaction, such as a fever.
Well, it takes longer to infection to be clinically relevant.
Mhm.
Exactly.
But how long would that take for a typical post-surgical infection?
I'd say at least 5 days, give or take a
Good
week.
number, good number,
Mm.
good number. 5 days to 3 weeks is the usual time frame you see a post-operative relevant infection.
Okay.
Mhm.
Okay, that's how long it takes. So is it possible you have infection next day? It's possible, but unlikely.
Correct.
So,
Correct.
But the nurse is calling you now. But patient has fever. It's 99.7.
Ooh.
No, what did you say?
Oh, Dominic.
I would go, so that's not a fever. Maybe they're just under too many blankets. A
So
fever
what-
is 101.4.
Which is in Celsius?
38.
0.5.
38.5.
38.5. That is what we consider. Now, and then the nurse goes back and calls you back, Alyssa, says,
Yes.
you know, the temperature is of 101.6. Patient does have infection. What do you say then?
I would say that they would,
The surgery was today.
Right.
Tonight, nurse is calling you.
at this point, I would still continue to say, just manage the patient's symptoms, give them some antipyretics, get that fever down and monitor. They're going to be okay.
But maybe we can do a little more.
Well, you
Tell them
could run
to-
some
to-
blood
to-
tests.
No, you can tell them to use the incentive respirometer
Spirometer.
and so on. Why is it not unusual without infection to have temperature, even temperature in the first 24 hours after the surgery? Dominic, what do you think?
So there's a process. Okay, first, incentive spirometry is a small little device that you kind of blow into to get
Mhm.
your lungs more patent, because a lot of the times during surgery, you are no longer really operating your own lungs. We're doing that for you. And a lot of the times after that, you can get atelectasis, which is something that will cause your temperature to rise.
What's atelectasis?
It's usually the collapse or the narrowing of different passageways in your lungs because they've been getting pressure. And so they kind of don't always hold up to that.
A collapsed
Part of
lung
your
is
part of your lung collapses, and every single time part of your lung collapses, your body goes crazy. Says,
Mhm.
what's going on? I gonna go and look at that, and
Mhm.
Mhm.
your temperature rise.
Yes.
Okay,
Yes.
even without infection,
Mhm.
even without actual clinical infection, if you have a atelectasis, you will have a fever.
Yeah, it's just a way for the body to get all of its little workers to locations faster. you know?
Yeah, and it increases your
marker. Yeah.
No, what is fever? That is what everybody think fever is fever. Now I'm going to go even further. Why does fever and diarrhea exist? Let's start with diarrhea. Why do we have diarrhea?
To
Expel.
tell us that something is wrong and to get rid of it.
Yeah. Yeah. We don't want that. Goodbye. Goodbye.
Get rid of it.
My GI is willing to sacrifice precious water to get this out. We must hate it.
So is it a wise idea to give you something stop your diarrhea?
No.
Okay, now fever. Fever. Why is nature want you to have fever?
It one tells us something's wrong. Two, it tries to kill it.
As a matter of
Inhospitable.
fact, your immune system is so much more active when you have your
Mhm.
cells start
Mhm.
working higher. Just the fact of increasing your temperature few degrees kills 70% of the bacteria,
Mhm.
Mhm.
70 to 80% of the bacteria. So, yeah, if you have fever, just keep reducing the pressure. Your body wants to go. No, at 43 degrees Celsius, then it becomes dangerous. Then you have to
What
really
does that
treat that.
translate to? About 108 or
107.
107? Okay.
Yeah,
So,
107.
The way I kind of like to think about it, or at least I did in school,
Deadly.
is
Temperature itself
a lot
becomes
like
deadly.
meat. When you're cooking meat, you cook it because you want to get rid of the bacteria, which is good. You don't want to just eat the raw meat unless you're a psycho. But if you cook it too much,
I am a
It's-
raw.
it's
raw
over.
But,
meat.
but what happens if you have fever? You feel sick
Right.
Mhm.
because your body wants you to rest. You feel sick so you can rest. Temperature goes up to kill the bacteria and immune system work. But at certain point, it become a renegade and
Mhm.
kills you. So we have to have judgment there.
yeah.
But so patient has high temperature in the first 24 hours after the surgery. It's 101.8. So it is the first day. What's your treatment? Symptomatically and incentive respirometer, get out of bed, walk around and so
Mhm.
on.
Mhm.
But now it's the second day. What now?
Do they have a catheter?
Yeah, we went through this. We were discussing mildly the 5 Ws that we learned
Go
in
ahead.
PA school. Now, we discussed mildly you can have the waves, which has to do with cardiac. It's the very first thing that we can have. But next, what did we come down to? Water?
Yeah, that's it. You could have a UTI.
Water, yeah, being UTI. A lot of our cases, well, not so much ours, Dr. Abbasi's per se, you get a catheter, meaning we are introducing, even if the most sterile techniques.
And that is what we do important. If a surgery is less than 2 hours, you don't need a catheter.
Mhm.
What percentage of our surgeries are less than 2 hours? You have the data. 95%.
I was
Yeah, I was gonna
Thank
say,
you.
I'm trying to think of one that
95.
wasn't less than 2 hours.
So most of our surgeries we can do without the catheter.
Mhm.
That's advantage already there.
Yeah.
Oh, yeah.
What is the number one nosocomial infection in hospital? What is the number one reason for infection in the hospital?
Probably UTI.
UTI.
Yeah. Like you go in and let's say you're doing plastic surgery or something, you have a horrible
Especially
and you
the
have to
older you
do
are, the more susceptible
So-
you
a
are.
9-hour
Two,
surgery.
3 days after your surgery, but by the way, most of our patients don't stay 2-3 days after surgery. But let's say 2-3 days after the surgery, they call you, patient has fever
Mhm.
and so on. 9 out of 10 time or 8 out of 10 time is probably UTI.
Mhm.
So that is why we take the catheter out latest first postoperative day in the morning.
Mhm.
Oh no, patient is uncomfortable, cannot go to bathroom. It's more reason for them to get out of bed
Right.
to go to
Mhm.
bathroom. So that is a fight worth fighting because what do some nurses want? If nurses want the patient to be comfortable sitting in the bed and
Heck, they'll give them a bedpan.
no, but what do
Don't
we
give
want?
me-
We want the
no.
patient to get out of bed.
Mhm.
Correct,
Mhm.
And then that-
absolutely.
That catheter not only is a source of infection, but as well, it prevents them to get out of bed.
Mhm.
Atelectasis and UTI.
And
Mhm.
you know as well as I do, a back surgery it's a big surgery. What's the number one thing we hear our patients? They say, I don't want to get up. Oh, moving
every-
kind of hurts.
Every time they don't get
Yeah.
out of bed, it makes it harder to get out of bed. So
Mhm.
early ambulation is important.
Yes.
Yeah,
Okay.
absolutely.
So, second day, they call you, patient does have temperature. And so what do you start to do at the second day, not the first day? Second day after spine surgery, the patient does have fever.
One, how big is the fever? How long has it been going? What symptoms do we have along with it? Are we having?
Analysis too.
Yeah. Well,
Okay, well, you examine the patient. What else? What else do you do?
Get a little urine culture, check it out.
Labs.
UA, urine analysis, urine culture.
Mhm.
You look for what do you look in urine analysis?
bacteria in the urine.
Urine
Ketones and
analysis,
stuff.
not urine
Oh,
culture.
oh. Well, yeah, ketones. No, that
Nitrate.
would be
Nitrates.
leukocytes.
Well, nitrates are a sign that
That would be
bacteria
coli.
have been reproducing.
Mhm.
You look for certain nitrates and so on in the urine.
Specific gravity can tell how.
Yeah, but
But-
urine culture, you look for bacteria because
Mhm.
urine should be sterile.
Mhm,
Yeah.
correct.
No bacteria, no cells in it.
Mhm. I should just have
No
ammonia.
pests, no nothing.
Yeah, so urine analysis, urine culture. What else do you do for that patient? Good.
You could
Or
get
you-
a
Chest
CBC.
X-ray.
Mhm.
Oh, yeah, to check for.
Yeah, I mean, if they have
Exactly what we
atelectasis and they're
talked
not getting
about.
proper spirometry and they're not walking, they're not.
Yeah, urine analysis.
Especially if they're in the hospital for longer
Yeah.
than 2 days.
And you talked about something else you just said, I just interrupted you. You just started mentioning that. So urine analysis, urine culture, chest
Like a
X-ray.
CBC, check
CBC.
for white blood counts and.
Okay,
the
so
trends.
CBC comes back. Oh, I'm the nurse. Oh, CBC is high. It's 14 and a half. It's high.
So we got some sort of infection somewhere. What did the UA say? What did the chest X-ray say?
But is 14 and a half after surgery unusual?
No,
What is unusual?
20,
22.
22?
2022 is unusual.
Hmm.
Is 17 unusual? No.
Not after surgery per se.
No, if you have a surgery, your white blood cell goes up because
Mm.
that's what's fighting the infection.
Yeah.
That's why. So 3 weeks after the surgery, CBC is 16. Is it still abnormal?
I'd
No.
16, yeah, I thought you were gonna go with like a
So,
19 or
right
something.
after
and
the
like-
surgery, the CBC
Yeah.
white counts can go up to 20,
Okay.
and then it should drops like
Yeah.
1,000 a day or something like that.
And that's why trends are so important,
Yeah.
because if I'm watching this thing and we come to week, let's just be nice, week 2, and I've just watched you go from 14, 15, 16, and today you're at 19.
Hmm.
Well, let's make sure we maybe we didn't get the UA
Trends
early
are
on
good.
because
Trends are good.
Do you know what's even better for trend than CBC?
With differential? I-
Well,
I-
yeah. Yeah, I was like, I mean, I wanted to.
Spin
What
out
are the
straws.
two? What are the two indicator for as well infection? But you can get a trend and it gives you a lot of good information. You guys know it. No,
I'm sure we
just
do.
on top of your tongue. It's
Hmm.
ESR, CRP.
Oh,
Oh, okay, my
Inflammatory
gotcha.
disorders.
Yeah.
Explain what they are. Go ahead. You say what CRP. You tell me what ESR.
I mean, they're generally related
I
usually.
was just gonna say.
No, it's not related. These are two
I
different
use
things.
them when I try to measure how much inflammation we have in our body and the amount.
What's the
Typically-
ESR?
Erythrocyte sedimentation rate.
What is that exactly? I did it myself
Mm.
because you guys are too young. You just send it to the lab. And this
Exactly.
is something we used to do in the
You
floor.
tip it and see
Oh, wait,
how long
really?
it takes to get,
You get
Mm.
you get the
Something.
patient's blood to put it in the long tube,
yep.
Mm.
and then you put like one of those egg
Timers.
timer,
Mhm.
the kitchen timer.
Mm.
You come after certain time and see how
long
much
it
of the
took to
electrocyte,
settle. Mhm.
because if you have lots of inflammatory proteins, things become more smooth and it falls faster.
Oh.
Those protein is like oil,
Mhm.
make the erythrocytes they
Mm.
fall faster.
Mm.
What CRP stand for?
Reactive protein.
C
Yeah.
reactive protein.
Mm.
What is that?
In the C, like cytokines usually.
Well, it is a kind of cytokines that we can measure easily,
Mm.
and it means how hard your body is reacting to
Okay.
any kind of inflammation, any kind of inflammation,
Mm.
bacterial or non-bacterial. But CRP is actually more better indicator that how it falls, goes up and down, indicator of how much inflammatory reaction going in your body. ESR, it's still the old way, still work
Yeah.
and so on. So we went from UA, urine analysis, urine culture,
Hmm.
chest X-ray, examine the patient, look at the wound. Is it
Okay, so you get a lot from talking with the patient. I mean,
And then we talked about the ESR, CRP, white
CBCs.
counts,
Mm.
and then chest X-ray, we talked about that. What else? Blood culture.
Yeah.
What is a good time to get a blood culture, and what's another good time to get a blood culture?
Get a blood culture before you start antibiotics.
At the peak, and before antibiotic.
Yeah, well.
Okay, and then you send it. You get a bacteriogram. What's growing? What's not growing?
Mhm.
But you have to get it at the peak.
Right.
Like, oh, patient had the temperature of 102. Oh, get a blood culture. What is the blood? What the temperature now? 98.
Right.
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 Okay, so those details do matter. Okay, so, but then you have done all the diagnostic and so on. That's just statistically, it's more likely it's a UTI in few days after the surgery than anything else.
Right.
Actual wound infection is more common 5 days to 3 weeks after, to 4 weeks after the surgery. Now,
Okay.
patient comes to you and says, doctor, I have an infection here. So what are the clinical signs? You look at the wound, what are the clinical signs of infection?
Heat.
Yeah.
Is it warm? Is it
3R,
spreading?
have you all guys
The
heard of
rubor. That's
rubor?
redness.
Yeah, rubor is red because it's hyperemic,
Mhm.
okay? More blood there to
Right.
bring infection thing. It's swollen, it is warm, and
What am I missing? Warm, swelling, redness, spreading.
Usually a little
Painful.
itch. Yeah.
Okay. Yeah.
painful,
Pain is typically the first thing that our
Yeah.
patients come to tell us is nowhere.
painful,
Well-
swollen, red. And then how do you differentiate it from allergic reaction to staples?
The to me, that's more spread. If it's
Yeah.
staying localized around the area of the staples, that's
Red.
If it's a
If it's
diffuse
infected,
reaction.
it's
diffuse.
diffuse.
That's a good word.
Whereas, and if you're just red around the staples,
Mm.
or just
Affected.
this, well, how do you know it's not the early stage of the infection? You don't.
No.
Mhm, yeah.
Until you have other, you put the whole picture.
Mhm.
You involve like, if there's a question, you involve more things like fever, chill.
Mhm.
Have you had fever?
Systemic type reactions. How long has it been going on is typically,
Yeah.
you're not going to get a fever on the first 2 hours of an infection starting. It
Yeah.
takes time.
So patient comes to you, you're still not sure. You look at the incision, you listen to them, you look at everything. You're still not sure if it's infection or not. It is 5 days, or let's say 1 week, 2 weeks after the surgery.
Right.
It's a little red, but you're not sure if it's just a starting of infection or is it the reaction to the staple. But 2 weeks later, you should just take the staples out.
Yeah,
Yeah.
I mean, it's the time to go. So
So, but one of the most important thing is the wound healing properly?
Mhm.
Because a healthy wound will heal in 10 days,
Mhm.
5 to 10 days. It is a good sign that it's healing.
Mhm, mhm.
Another is drainage.
Yeah.
Yeah.
Now, a wound that's healing, stop the drainage. But if 2 weeks later after the surgery, if you still have a drainage, yes, still possible,
Mhm.
but you still have a subclinical infection. Doesn't mean that it's infection that you need to take to OR. As a matter of fact, taking a patient to OR is the last thing on the list you are going to do.
Yes.
But if there's still drainage after 2 weeks, you have to be, your alarm has to go up. You
Mhm.
have to see the patient every day. You start the patient on not one, but 2 antibiotic. You keep the area clean. You maximize the
Mhm.
other things that you can do for the patient, including, good nutrition and
Mhm,
vitamin
mhm.
C and so on and so forth. So the drainage, even if it's serosanguinous, now obviously if purulent material.
Yeah, a big difference. Big one is a very specific, sensitive. Okay, well, would you look at that? That's bacterial exudate.
I'm going to tell you something very funny.
Oh.
I'm not Native American. I'm not native English speaker.
Mhm.
In my residency, they took one of my progress notes, they magnified it, copied it, put it on the wall of our conference room because I was describing an infection of a patient where I was practically saying patient has purulent material coming out of
That
the
era.
and I, instead of saying purulent material, I put PUSSY.
Nice.
And that-
They blew that up.
and for me, that was just purulent material coming out of the incision. But
Right.
I didn't know at that time that
Yeah.
we have another meeting.
Your chief president is looking at that going.
Exactly what he did. Chief president took it, make a big thing.
Yeah.
And you never made that mistake again, right? Until we talk about a little.
And even at that time, even when they put it on the wall, that was way over my head.
Yeah, you're probably like, wow, was that a good note or something? They really like that one?
That's what I thought until they all chuckled and so on. And so something beyond that is going on. So purulent material coming out of the incision, always a bad sign.
Hmm.
So about 2,500 years ago, Socrates says, "Obi pus ibi evacua." What does that mean?
I don't know.
Oh, you know it. Just dissect that. Obi
Upside.
pus ibi evacua. Wherever pus evacuated.
Oh, okay, okay.
Lancet. Have you heard
Mhm.
that? The old surgeon, they weren't surgeon, they were barbers. They had the sharpest knife. And if you come with a boy, they just lance it, they let it out.
Okay.
And so, number one, if the patient come to you, there is a purulent material coming out, do not stop that purulent material come out.
Yeah, yeah.
Because that's how they become septic and die.
Mhm.
Mm-mm.
If anything,
Why we
open
drain
it up.
abscesses.
Why we drain abscesses.
Mhm.
Never stop the purulent material, not the other one. I was going to say. The purulent material.
Oh, pure- I can't
Come
even
out.
hear you.
Open it up. If you have to, you put some gauze in it to keep it open.
Mhm,
You
mhm.
can wash it, you can
You're painting.
read it, but you never stop it to come out.
You don't close it until you are for sure that
Yeah,
it's good.
there's nothing else left there. You let it heal from bottom up,
Mhm.
granulate, and then now we have a wonder weapon in when we have infection. It's called wound vac.
Wound bags. Oh,
Like,
yeah.
I have an actual video about how to apply it and so on. You should go watch it because
Really?
one day you guys might be
Oh, yeah.
applying it.
Mm.
So what is a wound vac?
It is a device that is put over a wound to help it heal faster, close faster, for whatever reason, help the body do what it's not able to.
It's an accumulation of 2,500 wisdom, obi pus ebi evacua, meaning wherever pus evacuated,
Mhm.
it's actively sucking infection material out of the wound
Yeah.
and it's contracting the wound, making it smaller and smaller as it goes. It take the blood from deeper tissue, bring it up, nutrition,
Mhm.
take the
Yeah.
bacteria out. It is magic.
Yeah, it's a nice little, the tiny little black sponge, make that wonderful negative space there, and just, as the negative space does, pulls everything.
Negative pressure, yeah, it suck the wound, make the wound smaller.
Mhm.
You just have to make sure there's a video about that. That's one of my most viewed video. And people
He's
just
proud.
no, but there are lots of people go there and say, but you did that wrong, you did this wrong, and so on. Give me a break.
Yeah,
Yeah.
to be expected at
Yeah,
this
so-
point.
But then it makes the wound smaller and smaller, and it's magic. So, But antibiotic is always important, but you have to be selective with antibiotic. You don't give antibiotic until you're sure or you're pretty sure it's infection, but then you whack it double, triple antibiotic. So in perioperative time, we give Ansef. Sometimes after that, gram-positive, you give Keflex. But if you have an infection that you're concerned about, I give usually ceftriaxone,
Okay.
which is stronger than Ansef, but then I double it with vancomycin and Lovenox.
Okay.
You add as well some gram-negative to it,
All the coverage.
or Flagyl and so on. So you
Oh,
either
okay.
don't do it or do it right and do it long enough.
Mhm.
So otherwise, you're just selecting.
Will you
Resistant.
typically?
Yeah,
take
we're just
the
breeding a
blood
stronger
culture
bug.
And then hit them with all those antibiotics and then tailor after the culture?
So let's
or
say
is-
patient comes and I have a subclinical or clinical infection. I make sure that everything's out.
Yep.
If I need to do incision and drain, I open it up. And then if you do hem wound vac, you're good almost to go. But if you are trying to prevent the surgery
Mhm.
and so on, you lance it, you open it up, you drain it, you wash it, you install even some vancomycin powder
Mm.
there, but then you put them at least on double antibiotic. It says cephalosporin at least second or third, even better third generation, and something that Lovenox that has both gram-positive and
Sure.
gram-negative.
I love cephalosporins.
Now, vancomycin is actually a miserable antibiotic. It's a miserable antibiotic. Why?
Why?
I always thought it was the sledgehammer because it'll knock out your gut flora.
Yeah, pretty much.
No,
Will.
not that. Vancomycin is worse for all the bacteria except MRSA.
MRSA.
Yeah.
Okay, that's the only time. So if you have somebody that's MRSA, you don't just give vancomycin, you give vancomycin and Ansef.
Hmm.
But if you do that, like, if somebody has history of tomorrow we are doing a surgery on patient who has a positive MRSA and so on. So we are not going to replace Ansef with vancomycin. We are going to give vancomycin and Ansef because vancomycin is the most miserable antibiotic for all bacteria except MRSA. So, but you have to pay attention. If you give vancomycin, you cannot give it at the same time like Ansef because they participate together. They become a crystal.
Oh, really?
And both of them become ineffective. You have to give it through a different line. Or
Yeah.
first give the vancomycin and then give Ansef.
Huh, how far apart?
At least, no, well, you can give it one arm vancomycin, one arm
Right.
Ansef, or you can give first vancomycin. Once you stop that, then you can
Okay,
give Ansef.
okay.
As long as
so-
you flush it.
Nearly immediately. All right.
As long as they are not given together,
Gotcha,
that's good
gotcha.
enough. Okay.
Okay.
So that is, but if ever you have to give that both, that's what you need to pay attention to. Now, so then let's say somebody has bacteria close to hardware, which we put sometimes. That's a big deal.
That's not fun.
So you try to save the hardware as much as you can. You open it up, you take all the bone chips away, you wash it with, sometimes you do have irrigation, like you put two drains through one drain.
I
you put-
love that irrigation device. It looks like a water gun and it pushes out and sucks.
No,
in
no,
at
I'm
the
not
same
talking about the
time.
jet lavage. That is the jet lavage you're talking
Jet
about.
lavage. I
The
love
jet
that.
lavage, you put antibiotic solution, you with pressure, you put it on the tissue and you wash them out. Sometimes I have done it. They don't do that often anymore because I don't have that many infection. I don't have.
I can. I have not done one with Dr. Abbasi.
Yeah, we're living a bit in the theoretical sphere here.
Yeah, no, but sometimes what you can do is put two drains, actual drains.
Oh, okay.
You put a bag of vancomycin or some antibiotic solution. You irrigate the wound internally with one bag. This has antibiotic, and you use the other drain to take it out. So
not
antibiotic
seen that.
irrigation. That goes over a day or two and so on,
Sure.
and wash everything out and so on. That is something you used to do. If obviously all of that doesn't work, then you have to open it up, do incision and drain, do a wound vac and so on, jet lavage,
Yeah.
which is very efficient and so on. But the regular spine surgery has 3 to 5% risk of infection. If you do a big case like scoliosis, sometimes they have 15, 25% risk of infection. Now, those scoliosis, they are big deals.
Yeah.
Okay, so until 2016, there was a paper, they said they have 40% complication rate. 4 of 10 patients have complication rate. Then the study came out in 2019 says 60% complication rate.
Jeez.
So
It's
you
getting
guys don't
worse.
see that.
No, thank
Because with the
goodness.
surgery that we do, our complication is so low, that become irrelevant. So in a way, you guys are spoiled not to see all the things that can go wrong in spine surgery.
Spoiled.
Well,
It's
okay,
a good thing.
good
It's a
thing.
good thing to
Yeah,
be spoiled at this
for
point.
the patient is a good thing.
True.
And that is why I saw a patient today from Alaska,
Mhm.
one patient from New York, one patient from Texas, one patient from somewhere in the East Coast, two patients from California. Just today, I think patients are smarter. They know what's the difference between 5% risk
Mhm.
of infection and 0.3% of infection. One
Mhm.
patient was just telling me all my results, have read me and so on. So, but these infections are big deal.
Yes.
Mhm.
We see it very rarely, but you still need to be aware of that
Yeah.
and be able to treat that. And so what have we missed talking about infections?
Well, I think we should talk about not that blood clots are are an infection, but that is also a very common post-operative, something that we need to be aware of because Dominic and I also
That's
often get these
important because
question or
blood-
calls from patients.
one of the symptoms of blood clots in the leg or DVT is
You get a
Heat,
fever.
Temperature.
pain,
Yeah,
swelling,
you get a fever.
temperature.
all of
high
the same
temperature.
symptoms that we kind
Yeah.
of just described.
you have to be
Redness,
able-
swelling,
You have to be
heat.
able to distinguish between that. Now, let's say, okay, well, let's say I come in and how do you rule out that I have a DVT or not?
Well, actually, typically I do an ultrasound.
Yeah, I was gonna say final point.
Well,
Just
I mean, that's the ultimate, well, not
like
ultimate.
the end is I go, okay, can I see it? But
Do the
before that,
Hoffman's,
yeah.
Yeah, Hoffman.
where you dorsiflex or whatever,
Yeah.
is that the correct term? Dorsiflex the
Hoffman.
foot and then you
Hoffman.
squeeze.
Hoffman is the.
Oh, well, I do the
Holman.
So-
Homan's
Homan. So, yeah.
sign.
What you
But
do,
yeah,
you
that's true.
push on the veins to
Mhm.
see if they are painful.
Mhm. And
That's all what it is.
you can also sometimes you can just look at the calf and be like, well, that was a different size.
Thicker. It's colder. It's thicker. It's
Mhm.
colder. It's painful.
Mhm.
And the more important in the calf,
Homan's
do
sign,
it in the gastrocnemius.
Mhm.
because it
I'm
can
sorry,
move up.
gastrocnemius and the hamstring.
Correct.
Because those that are in the thigh and pelvis are way more dangerous than those that are in the calf.
Yes,
Thank you.
absolutely.
I have tried to explain this to people. I said, catch it in the calf. That's okay. And the calf is not an emergency situation. The closer it gets to the heart.
That is become more dangerous. Now,
Yes.
So can have similar kind of thing, but well, I did surgery here. I don't expect really infection here.
Mhm.
Can be.
Yeah, yeah.
But DVT, you have to distinguish between these two.
Mhm.
Okay, so anything else we need to talk about infection before we call it? We covered a lot.
Yeah, I was gonna say we kind of went from A to Q,
And
so
we could cover it in more depth, but
But
I
that's
think
enough, I believe.
it's a good overview.
Okay, then let's call it.
Absolutely. Well, that was Infections with Essence of Medicine. My name is Alyssa Hopper.
Dominic Moore.
And Dr. Abbasi for us. Thank you for joining us.
Thanks, guys.